Hello and welcome to Season 2, Episode 17 of the Physician Assistant Exam Review Podcast. Today we're going to be covering hypotension and CHF. I'm Brian Wallace, the host and creator here at physicianassistantexamreview.com, where you can find all of the notes and review material over on the website. I highly recommend you head over there. This episode has been a little time in the coming. We finished, cardiovascular medicines was the last episode, and then I've taken a little bit of a break. I had a little bit of a overscheduling issue between the holidays and some remodeling that has not gone according to plan here at my house. A couple other things going on. I just have not been able to get to record this in the next session. So here I am today sitting down to do it. I'm going to talk a little bit more about what's been going on with me and how that affects you. And if you are overscheduled and going out of your mind with so many things to do, you may particularly like today's study tip. So hang around for that. Thank you once again for joining us. If you're new to the show, thank you so much for being here. I look forward to working with all of you on a regular basis. So we're in the middle of the cardiovascular system in Season 2 here, making progress. We're going to cover hypotension and CHF today. So let's go ahead and get started with our priming questions. Define orthostatic hypotension. Define orthostatic hypotension. This is going to be a decrease in systolic blood pressure of 20 milligrams of mercury or a decrease in diastolic blood pressure of 10 when going from lying to sitting or sitting to standing. So a drop of 20 systolic, drop of 10 diastolic when you go from either lying to sitting or sitting to standing. Is the cough in CHF productive or non-productive? Person comes in with a productive or non-productive cough with CHF. It's going to be non-productive. We'll get into that in a little bit. Those are our only two priming questions for today because our section is going to be relatively short. So there's not a ton of questions that are going to come out of this. Let's begin with hypotension. Hypotension is low blood pressure. Orthostatic hypotension, like we just said, is a drop of 20 milligrams of mercury in diastolic or 10 milligrams of mercury. I'm sorry, I said that backwards. A decrease in systolic blood pressure of 20 milligrams of mercury or millimeters of mercury, or a decrease in diastolic blood pressure of 10 millimeters of mercury when going from lying to sitting or sitting to standing. This hypotension and orthostatic hypotension is a significant cause of syncope and falls in elderly patients. So this is how people fall down and break their hips. Causes low blood volume, so dehydration, reduced cardiac output for one reason or another, paroxysmal cardiac dysrhythmias, and certain medications can cause this. Well, not certain medications, blood pressure medications. I think that lower blood pressure can cause hypotension if you overtake them. Physical exam findings. Again, let me see if I can butcher this one more time. A decrease in systolic blood pressure of 20 millimeters of mercury. There I go. Millimeters of mercury, or a decrease in diastolic blood pressure of 10 millimeters of mercury when going from lying to sitting or sitting to standing. That would be orthostatic hypotension. If associated with a heart rate increase of more than 15 beats per minute, the problem is probably low blood volume, okay? So watch the change in heart rate. Again, if associated with a heart rate increase of more than 15 beats per minute, the problem is probably a low blood volume. You can tell I'm out of practice. Treatment. You're going to treat the underlying cause. So if we think it's a low blood volume, you're going to give fluids, right? We're going to go over the blood pressure medications with the patient, see what they've been taking, see if we're giving too much, see if they're taking too much. All of these things. We're going to check EKG and see if we can get if there's an issue with the rhythm. All of those things are how we deal with hypotension. Next, we have congestive heart failure, CHF, as it's commonly referred to. CHF is the inability of the heart to pump enough blood to meet the needs of the body. The inability of the heart to pump enough blood to meet the needs of the body. Typically, this involves fluid overload retention and decreased cardiac contractility and decreased cardiac output. Causes include congenital heart disease, heart valve problems, severe anemia. Acute exacerbations are things like after the holidays, if you have too much salt, which makes you retain too much fluid. Excessive alcohol can cause this, and excessive physical activity can bring this on in an acute situation. Arrhythmias, pulmonary emboli, systolic dysfunction. In this case, cardiac contractility is decreased. CHF is very common post an MI, myocardial infarction, so a heart attack. Coronary artery disease can cause this. Chronic alcohol abuse can cause this. Myocarditis, diastolic dysfunction, abnormal filling of the ventricles. If you don't fill correctly, you don't get pressure, you don't get the fluid going out, right? Chronic hypertension, same issues. Left ventricular hypertrophy and diabetes are all on the list of causes for congestive heart failure. Remember, congestive heart failure is the inability of the heart to pump enough blood to meet the needs of the body. Blood is not getting pushed out of the heart. Clinical characteristics. Patients come in with exertional dyspnea, so meaning they get tired as soon as they start to exercise at all. So how many blocks can you walk? How many flights of stairs can you go up before you have to rest? As disease gets worse, this dyspnea gets worse and it becomes a resting dyspnea also occurs. Paroxysmal nocturnal dyspnea. So the question here is, how many pillows do you sleep on, right? We want to see how elevated the person needs to be. If they're laying flat, do they have trouble breathing? And then a non-productive cough. Again, those two, these are all going to be because fluid backs up into the lungs a little bit. So then you get extra fluid, you get extra blood volume into the lungs. Let me see here. In the horizontal position, there's a redistribution of blood volume from the lower extremities and the splanchnic beds to the lungs. In normal individuals, this has little effect, but in patients in whom additional volume cannot be pumped out by the left ventricle because of disease, there's a significant reduction in vital capacity and pulmonary compliance with the resultant shortness of breath. So that's paroxysmal nocturnal dyspnea brought on because CHF, they can't pump the blood out. They can't bring it through. Physical exam. So cyanosis is one physical exam finding. So blue fingertips, dyspnea, again, shortness of breath. Blood pressure may be low, normal, or high, so that's not going to be a real good indicator, but if it's off, then we may be looking at CHF pulse issues. Tachycardia is one way to bring one way to bring up cardiac output is to increase heart rate. Okay, so you may find that these patients have tachycardia in an effort to counteract the effects of CHF of poor contractility. The pulse may also be weak or thready. You can get pulsus alternans, which is alternating strong and weak beats. You may see Cheyne-Stokes respirations or breathing, which is an abnormal pattern of breathing characterized by progressively deeper and sometimes faster breathing, followed by gradual decrease that results in a temporary stop in breathing called apnea. Jugular venous distension or JVD. Here you have the patient sit at 45-degree angle. The jugular vein pulsation higher than 4 centimeters above the sternal angle is considered to be elevated venous pressures. You get that from buildup because the heart is not emptying, so you get buildup back into the venous system. Displaced apical impulse, it should be in the midclavicular line in the fifth intercostal space. So if it's displaced, it's moved over. It tends to be from, this may be more of an indicator of an enlarged left ventricle, something along those lines. Dullness to percussion at the base of the lungs. You may get fluid buildup in the lungs. Heart sounds, diminished first heart sound, S3 gallop may be present. Fourth heart sound, S4 may be present. Murmurs may indicate possible causes, so we'll talk about valvular issues at another time. But these are all just, there's nothing super distinct that says, boom, this is CHF. But there's all of these little pictures that you're looking for, all these little things. Breath sounds are included in there, rales, so you get that fluid buildup. And wheezing, you can get that with the Cheyne-Stokes breathing, or with, paroxysmal nocturnal dyspnea, you can wake up with wheezing. Hepatomegaly, same thing. You get that venous buildup. Hepatojugular reflex, which is, again, the patient sitting at 45-degree angle. Pressure is applied to the abdomen for about a minute, and if the neck vein height increases by 3 centimeters, this test is positive. So again, you're creating pressure, trying to get the heart to clear out the fluids you're kind of backing up, and it's not working. And then you can get lower extremity edema, so swelling in the lower extremities. Labs and studies for CHF. On the X-ray, it's easy to ask questions on X-ray. In fact, at the end of this, I have some questions. I have one of the questions based solely off the chest X-ray. And just based on the fact that it's so easy to ask the questions and to create them, I would learn these. So on chest X-ray, you may get cardiomegaly, and all of these you may have for CHF. They're not definites. Pleural effusion, so a ground glass appearance, fluid buildup in the pleural spaces is the pleural effusion. You may see that. Curly B lines. These are short parallel lines at the lung periphery near the base. You may get periobronchial cuffing, which is interstitial fluid building up around the bronchi, and when you see them on end, you see a circle. I suggest you pull up a picture so you can get a better idea of that. Anytime I've tried to link to these things on the internet, in season 1, I had a whole host of x-rays linked out from the webpage. The problem is they all break. Eventually somebody changes around their pages and all those links go down. So I've sort of stopped doing that, but it's so easy for you to find. Just Google peribronchial cuffing, curly B lines, pleural effusions, all those things. And then bat winging or a butterfly shadow, which is an enlarged hyla alveolar edema, or a water bottle or boot-shaped heart. Those are all things to consider when we're talking about CHF. All right, of course, you're going to get an ECG. You may find arrhythmias. You may find history of MI or evidence of an MI or active MI. You may see left ventricular hypertrophy. Again, that, what did we say earlier? The displaced apical impulse due to that left ventricular hypertrophy, pericard, and you may find a pericardial effusion. We'll cover EKGs and arrhythmias and things at a later time and get more detailed on that stuff. But I want to cover all of our definitions sort of up front, then we'll go back and hit all that later on in cardiology. Echo, you're going to get an echo, which is going to assess ejection fraction, assess ventricular function, and assess how the valves are doing. You may get a catheterization, which is going to better assess the valves and look for coronary artery disease. BNP, or beta natriuretic peptide, is an elevated BNP is a good indicator of CHF. However, it may not be as specific in patients who are old or have COPD. Okay, so elevated BNP points you in the right direction, doesn't necessarily, like everything else here, doesn't clinch the diagnosis, but points you in the right direction. You're probably going to order troponins to look for that MI, a BUN, CBC, severe anemia is possible cause of CHF, a BNP, electrolytes are usually normal, and a thyroid panel. As far as treatment goes, we're going to control the underlying cause if possible. So if we have an arrhythmia, we maybe treat that. If we have hypertension, long-standing, we're going to treat that. If we have a hyperthyroid, something along those lines, we're going to deal with that. If we have, we're going to try behavior modifications. We're going to try exercise, low-sodium diet, perhaps fluid restriction, maybe diuretics, these sort of things, medication. So yeah, diuretics was the next thing on my list. And diuretics, thiazide or loop diuretics with an ACE inhibitor, that's going to be key here. Beta blockers, inotropic agents like digitalis, digoxin, to help the heart contract more. All right, so that's going to wrap up CHF and hypotension. I know this one was short. The last one was long, and I wanted to just make sure I got this out at some point. So it is a little bit shorter on information, but that's okay. We'll pick up with more hopefully the next time we talk. Our study tip for today, this is going to be slightly different because what I want to do today is talk a little bit about what's been going on with me for the past week and how that what I've learned and what I've done can help you. For the past couple of weeks since Christmas, we have been completely insane at my house. It's all good. There's nothing actually wrong. It has just been crazy busy with the kids' sports, my in-laws being here, the holidays themselves, Christmas, was almost like a week of being with family, which is all good. Then we started a remodeling project on the house that, as some of you who have done these sort of things know, we're very happy with the results, but it is always, 2 steps forward, 3 steps back, 1 step forward, 1 step back, and eventually you get in the move in the right direction. But I've put down a laminate floor in my family room and taken it up and put it back down and redone some things several times. It's going well, but it is monopolizing much more of my time than I had intended. So my point is that I've been completely overwhelmed for the past month. Just, unable to get anything done that I wanted to. I had all kinds of plans for the physician assistant exam review community for 2017 and for this month in particular. I'm working on a couple of new projects, things I want to get out to you guys, things I think will be super helpful to you. Unfortunately, all of that has been put on hold. And what I finally realized, I was going crazy trying to get it all done, running back and forth, writing, working on a house, and I realized that, and I spent a ton of time with time management software. I'm a huge fan of it. I've got 3 different apps on my phone that do things for me. I've got a calendar. I am very well managed, let's say. I spend time reviewing my calendar. I spend time reviewing my tasks and my week and everything I'm going to do. And what I came to the realization was, and I think this applies for a lot of you, is it didn't matter how well scheduled I was or how I broke out my to-do lists and how the things on my list were things I really wanted to get done and things I liked and things I enjoyed. I simply didn't have time to get to them all. It just wasn't possible. There was no way to do it. It wasn't a question of when or how. It was just, I had to start saying no to things. I had to start being, in some ways, an adult and say, you know what? I love producing the Physician Assistant Exam Review podcast. I love doing this, but I can't get it done. There was a book project I'm working on to put out. I can't get it done right now. It had to get pushed back. Right now, the most important things for me was getting the floor finished and trying to go out to dinner with my wife. In fact, one of the things I sent out an email not too long ago talking about, we had got a new TV for Christmas, and it came with a Roku box, and I wanted to set up Netflix so my wife and I could watch the new season of Gilmore Girls. We had watched it end, and she was really excited, and I wanted to see it too. And it was not until just this past weekend that I sat down, set up Netflix, and we were able to sit and watch it. So a month after Christmas, essentially. So just about 30 days before I got enough time to sit down with my wife for an hour and do that. So what I decided was I had to start saying no to things I liked, things I enjoyed, which included saying no to this show, to saying no to putting this material together, saying no to a lot of other good things in my life, because I had to get the important and the great things done and work in those. So my point for you is, and the point of this whole story, is just to say, sometimes no matter how well you're scheduled, no matter how particular you are about the things that you do, no matter how much you're paying attention, there simply is only 24 hours in a day. You can't do everything. You can't get it all done. On the days, my wife doesn't work every day. She does some consulting. On the days she works, we don't have great, nice dinners. Doesn't happen. We have to make choices on the things that we're going to do. On those nights, maybe we order pizza and it's planned, but that's what we do. We know we can't sit down and I'm not going to cook steak, and that's not going to happen. We have to make choices. And although there are things we really like that we have to cut out, we have to cut them out. We have to say no. And again, my larger point is, when you're taking your exam, when you're getting ready for your PANCE or your PAN-RE, I get emails from people more often than you can imagine, at least more often than I can imagine, saying things like, my test is coming up. I really need your help. I'm pregnant. I have a baby due in about 2 months. I have 2 little ones at home. I'm moving, and my husband got a new job, and I'm thinking of changing jobs. And my test is in 3 months. What do you think I should do? And I have no idea how to answer that question. That is just, there's so much going on. And this applies directly to students as well, because when you graduate, you're applying for your licenses. You're trying to get your exam taken. You're hunting for jobs. Most people are, since you're leaving school, you're probably leaving the location. You may be looking for a new apartment. You've got so much going on. You just simply don't have the time or the mental ability to handle all of this. So you need to start saying no to some things. Start telling people, no, this month I'm not looking for my new apartment. I'm going to have to extend my lease by a month. I'm going to have to move in with my parents for a month. No, I'm not going to PTO meetings, and I'm not babysitting the neighbor's kids this month because I can't do it. Now, you can come back to those things. You can come back to the things you love, like I'm doing here. I put the show off for about 2 weeks to try and get my life back together. It isn't really back together, but I was able to find a little niche of time to squeeze this in. You can come back to those things, but you may have to be an adult and say no to the good things so that you can get this done. It's easy to cut out the things you don't want to do. It's hard to cut out the things that you want to do, the things that are great in your life. But you may have to cut some of those for this period of time. I'm going to wrap it up there. Post questions. Let's jump into those. List 3 X-ray findings in CHF. 3 X-ray findings in CHF. Remember, I told you I was going to talk about this. You could say cardiomegaly, pleural effusion, curly bee lines, peribronchial cuffing, bat winging, or water bottle boot-shaped heart. List 2 lung sounds in CHF. 2 lung sounds in CHF. Rails, wheezing. All right, great. Well, that wraps up episode 17 with our hypotension and CHF review. Congratulations to all of you who have been in touch, who have passed your exam. I've gotten some amazing emails lately talking about people who have passed their exams and how well things are going for them. Congratulations to Janie, to Kathy, to Leah, to Crystal, so many people who have recently passed their exams. Congratulations to all of you. I know I do have a couple people who emailed me, in fact, this week, just a couple days ago, who have failed their exams. I will get back to you shortly and see what we can do to help you out there. Until next time, jump on the email list. There's so much good information there, and that's the best way that I can keep in touch with you and get you some great study tips, study information, and things you can do to improve how you get ready for your exams. So make sure that you go ahead and do that. Head over to the website, www.physicianassistantexamineReview.com, for all of the notes and, again, access to the email system. All right, great. Thank you. Take care, and good luck on your exams this week.